Morning.
Morning.
Pam, welcome here. Usually we get started sort of right at the half-hour point. So, yes, Gautam, you're going to make the introduction. Want to go ahead and get started?
Great. Nice to see you. Thank you.
Yeah.
Good morning, everyone. I'm Gautam Grandi, one of the...
Gautam, you're really soft. We can't hear you very well.
Okay. Good morning, everyone. I'm Gautam Grandi, one of the first-year cardiology fellows at VCU. Thank you very much for attending our Grand Round lecture series. I'm pleased to introduce to you our speaker, Dr. Pamela Morris. Dr. Pamela Morris is a professor of medicine and cardiology and Paul V. Kramer Endowed Chair in Cardiovascular Disease Prevention at the Medical University of South Carolina. She's the founder and director of the Seinsheimer Cardiovascular Health Program. Dr. Morris is a fellow of the American College of Cardiology, the American Heart Association, the American Society of Preventive Cardiology, the European Society of Cardiology, and the National Lipid Association. She served as the vice chair of the American College of Cardiology annual scientific sessions, ACC 19 and 20, together with the World College of Cardiology, and is the chair of ACC 21 and 22. Today's topic of discussion is lipid-modifying agents as a continuous success development, statins, PCSK9 inhibitors, and beyond. We're very grateful for Dr. Morris's expertise on this topic and look forward to learning from her.
Great.
At the end of the lecture, we'll have time for questions. Please submit your questions by the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credits for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and end of this presentation to 804-625-4041. For questions or to log in to your Cloud CME account, visit vcu.cloudcme.com or contact Shannon Instant. I'll now turn it over to Dr. Morris. Thank you.
Great. Thank you so much, Dr. Gandhi. I'm very grateful for this invitation to VCU. And I also want to thank the Congdon family for the privilege of honoring their family with this presentation. So thank you so much. I think it's very interesting with all of the training that you're doing now. Much of it is in interventional imaging, electrophysiology, et cetera. But suffice it to say that I think there's no question but that one of the areas of the greatest explosion in development is actually in preventive cardiology recently, and in particular in the area of lipidology and lipid management. And so what I'd like to do today is to take you on a little journey through the incredible history of the development of lipid-lowering agents. This is my disclosure, which has ended. So I'm going to start with a case presentation. So this is actually a real patient. So this is a 48-year-old gentleman who originally had presented to cardiac rehab following an acute MI, and then he underwent bypass surgery without complications. His family history is very interesting. His father had an MI at age 39 and also underwent bypass surgery. He died at the age of 44 of recurrent MI and had severe hypercholesterolemia. His brother had high cholesterol and underwent PTCA of a right coronary artery for angina at age 33. And his father died at age 42 of a, quote, massive heart attack, but his cholesterol levels were unknown. The patient had a history of high cholesterol and tobacco use. So when he presented to cardiac rehab, his labs showed, untreated at that time, a total cholesterol of 373 and HDL cholesterol 40, triglycerides of 115, and an LDL cholesterol of 310 milligrams per deciliter. Now, you might not, many of you are going to be too young to remember, but back in 1986, there was a real question about what were you going to treat someone? Obviously, a high-risk young gentleman with a high-risk family. But when you look at the LDL cholesterol treatment journey back then, in 1986, the available lipid-modifying agents we had were niacin, cholestyramine, and clofibrate. None of these was considered very well tolerated, safe, or effective, and those were the only agents available to this gentleman. Now, Lucky for him, lucky for our patient, Dr. Akira Endo was subsequently born in a rural farming village in northern Japan. He entered university in 1953. He was quite good in organic chemistry. He studied with Conrad Black, a Nobel Prize winner for his work on cholesterol biosynthesis. In 1971, Akira Endo and his group isolated compactin, which we later come to call mevestatin, from the fungus Penicillium citrinum. It was structurally similar to mevalonate, which is the product of HMG-CoA reductase, and it was a potent inhibitor of that enzyme. Now, this was first used to treat a patient with homozygous FH in 1987, and it lowered the LDL cholesterol from 1,000 to 700 milligrams per deciliter. But unfortunately, when it was used in animal studies, they found out that it had toxicity, specifically lymphoma. So the development of that was discontinued. Fortunately, Merck pursued this and identified lovastatin from another fungus. And lovastatin was the first statin to achieve or reach commercial availability. So we since have had the development of 8 statins, one of which, rosuvastatin, was withdrawn in 2001 for toxicity. But we now have 7 statins available to us, which were then available to our patient. Now, when we think about the mechanism of action of lipid-lowering agents, we need to remember that the majority of agents available to us, although we think of them as inhibitors of cholesterol synthesis or utilization in one way or another, all of these agents work actually by upregulating the production of the LDL receptor, and statins are no exception. Now, over the coming years, statins are now the most well-studied medication in the history of medicine. There have been nearly 200,000 patients enrolled in randomized clinical trials, placebo-controlled, primary prevention, secondary prevention, statin versus usual care, or statin dose comparison trials. What have we learned from all of these trials? Well, obviously, we've learned that lower is better and even lower is even better. When we look at the cholesterol treatment trial collaborative analysis, what we've learned is that for every 1 millimole, or about 39 milligrams per deciliter, that you lower LDL cholesterol, we reduce cardiovascular risk by about 20 to 25%. We have also learned that the benefits of statin therapy increase steadily over time. The longer and the earlier a patient is treated, the greater the potential benefit over the years to come. The other thing that we have learned is that we can regress plaque. This was initially demonstrated in the ASTEROID trial with rosuvastatin, where it demonstrated that rosuvastatin 40 milligrams over 24 months could regress percent atheroma volume for the entire vessel, decrease atheroma in the most diseased vessel, and reduce total atheroma volume. Now, following, it was kind of a drought there. If you think that the first statin was developed in 1987, it took another 15 years before we had a new pharmacological approach to lowering LDL cholesterol. And that was next with ezetimibe, FDA approved in 2002. Now, ezetimibe, it was an interesting agent because it was initially developed as part of a program to look for what we call ACAT inhibitors. Now, what they do is they form cholesterol ester, which is an effective mechanism to store and transport large quantities of cholesterol between organs. And also it prevents the toxicity of accumulation of excess cholesterol. It ends up that ezetimibe was a very weak ACAT inhibitor. So it did not work in the mechanism thought, but it did lower LDL cholesterol. So when it was approved in 2002, we actually did not know how ezetimibe worked. Subsequently, we found out that it was an inhibitor of the Niemann-Pick C1L1 transporter in the intestinal brush border and blocked uptake there along with other sterols. Now, again, as I mentioned earlier, even though it works at the Niemann-Pick C1L1 protein, or that's its target, ezetimibe actually upregulates the LDL receptor. Now, we know that when added on to statin therapy, it can reduce LDL cholesterol by about another 25%, also a modest effect on triglycerides. When we look at the trials of ezetimibe, the most important trial, of course, is the IMPROVE-IT trial. This was an acute coronary syndrome trial with more than 18,000 patients when ezetimibe was added to moderate intensity statin with simvastatin 40 milligrams, reduced LDL cholesterol from about 69 or 70 milligrams per deciliter down to about 54 milligrams per deciliter. And over 7 years, the hazards ratio was 0.936. Now, again, looking at the LDL treatment journey, we had another decade of drought here. Limidipide was approved in 2012, but only for homozygous FH. And let's talk about that for a moment. So limidipide is another interesting agent. First of all, if you think about microsomal triglyceride transfer protein, and I suspect that in your daily cardiology journey, this is not something you think about day in and day out, but it is incredibly important transfer protein. Because think about ApoB. So ApoB is the backbone of all atherogenic lipoprotein particles. What MTP does is to lipidate either ApoB 100 in the liver or ApoB 48 in the intestines. So in the liver, it forms VLDL. In the intestines, it forms chylomicrons. If you are to inhibit this, you will inhibit the production of the LDL cholesterol and inhibit the formation of chylomicrons. And that's exactly what limidipide does. Now, why this particle is so important, or this molecule is so important, is that it inhibits the production of the LDL and chylomicrons, is therefore LDL cholesterol, independently of the LDL receptor. Why is this important in HoFH? Many of these patients either have an absent functioning LDL receptor or a defective LDL receptor. Therefore, upregulation is not effective in lowering LDL cholesterol. Now, limidipide is a little bit problematic in that you can imagine if you don't form VLDL, but there are triglycerides and cholesterol around, you can get some hepatic fat accumulation. And in the intestines, if you're not forming chylomicrons, you may have issues with intestinal fat, and you can have some GI-related side effects. However, limidipide lowers LDL cholesterol by about 40 to 50% meaningfully in patients with hypercholesterolemia. You can see that although there's a little bit of an increase in the transaminases, a little bit of an increase in hepatic fat, that is stable over time and does not appear to worsen in long-term studies. Limidipide is currently an orphan drug. It means you have to go through, it's only available for patients with rare genetic diseases like homozygous FH. You do have to go through a prescriber training program and go through certified pharmacies. Now, only 3 years later, we had the FDA approval of the first of the PCSK9 inhibitors, that is evolocumab and alirocumab. Just to look at their mechanism of action very quickly, remember that both the LDL, when you have the LDL particle on the LDL receptor, they're both endocytosed. then typically what happens is the LDL receptor recycles back up to the surface of the hepatocyte, and the LDL cholesterol, or the LDL particle, is then destroyed in the lysozyme. Typically, the LDL receptor goes back and forth to the cell surface nearly 150 times. But what happens with PCSK9 is when that protein is present, it binds irreversibly to the LDL receptor and the LDL particle, thereby targeting that entire complex for destruction in the lysosome and inhibiting the upregulation or the recycling of the LDL receptor. Now, if you look at PCSK9, when this was discovered in 2001, they realized that loss of function variants in PCSK9 resulted in very low levels of LDL cholesterol and a substantial reduction in coronary heart disease risk. That made this PCSK9 protein a very attractive target for lipid lowering. We're going to go through this full slide in detail as we progress in the talk. But what we're going to focus on now first is the first agents that were used to target PCSK9, which were in fact the monoclonal antibodies. And of course, again, these agents upregulate the LDL receptor. The first agents were evolocumab, again administered sub-Q, as well as alirocumab, again approved in 2015. Two really important cardiovascular outcomes trials with these agents. Fourier was with evolocumab, nearly 28,000 patients with stable ASCVD and high-risk features, and then Odyssey Outcomes, nearly 19,000 patients in an acute coronary syndrome population, all on maximally tolerated statin therapy with or without ezetimibe. Now, both trials showed remarkably similar results. Both lowered LDL cholesterol by nearly 60%, 55 to 60%, quite dramatic lowering. Both had very similar results in terms of outcomes, an approximate 2% absolute risk reduction, a hazards ratio of 0.85 in two different CAD populations. Now, remember in the treatment journey that those agents were released in 2015, and our guidelines were subsequently published in 2018. So the guidelines then incorporated those agents into their recommendations. At that time, of course, those agents were also quite expensive, and the guidelines did include a cost-effectiveness recommendation. But since that time, there have been 3 additional agents that have been FDA approved. And I want to talk about each of these novel agents. And then at the end of my talk, I want to discuss about clinical guidance for how to incorporate these agents into your practice. The first we're going to talk about is bempedoic acid. Now, this agent is an inhibitor of the enzyme ATP citrate lyase. If you look on the left-hand side, you can see that in the cholesterol synthesis pathway, ATP citrate lyase is upstream of the rate-limiting enzyme HMG-CoA reductase. It inhibits that. Now, bempedoic acid is administered as a prodrug. You can see on the far left-hand side, it does have to be activated by ACSVL1. Now, this is interesting because ACSVL1 is only present in liver and not present in muscle, which is why this agent was developed specifically addressing the statin-intolerant patient population. Again, upregulating the LDL receptor. Now, in trials of efficacy for bempedoic acid in ASCVD or heterozygous FH populations, When added to statin therapy, it reduced LDL cholesterol of about 15 to 17%. When studied in patients with statin intolerance, it had a more robust reduction in LDL cholesterol, about 24 to 25%. This is probably not surprising. Thinking again back to the cholesterol synthesis pathway, if you're already inhibiting that pathway with a statin at the rate-limiting agent or enzyme HMG-CoA reductase, and then coming in on top, trying to further inhibit that pathway, it would not be too surprising that there's only so much you can inhibit the pathway. On the other hand, when you come in with monotherapy and statin therapy is not on board, you might expect to have a more robust reduction in LDL cholesterol. Now, just last year, we had the publication of the CLEAR outcomes, the cardiovascular outcomes trial with bempedoic acid, here published in the New England Journal and presented at ACC 23. This was a double-blind randomized controlled trial in patients who had had adverse effects with statins, 2 statins, or at least 1 statin and unwilling to try another statin, or they were advised not to try any further statins. They could take a less than therapeutic dose if needed. They were then randomized to bempedoic acid or placebo, and then the primary endpoint was the 4-component MACE of MI, stroke, revascularization, or CV death. There were almost 14,000 patients. This was a multinational trial. They were very pleased to recruit a nearly 50% population of women, although they were predominantly white. Baseline LDL cholesterols of 139 milligrams per deciliter. We'll see in a moment another important aspect about this trial was that nearly 30% of the patients in this trial were primary prevention patients, a group for whom we lack the cardiovascular outcomes data in some of these higher risk patients. So you can see here in terms of the LDL cholesterol reductions in high sensitivity C-reactive protein. On the left-hand side, a reduction both in patients on placebo over the follow-up period, but a 26% reduction with bempedoic acid. That would be a placebo corrected of about 10.5%, and then meaningful reductions in HS-CRP. Here you can see that there were statistically significant reductions in the primary endpoint, the 3-component MACE, which is MI, stroke, and death, fatal or non-fatal MI, and coronary revascularization. Now, subsequently, they published the results for specifically the primary prevention population in JAMA. And you can see on the right-hand side, the composite endpoint occurred in 7.6% of the patients on placebo, 5.3% on bempedoic acid, with an adjusted hazards ratio of 0.7, so about a 30% reduction in risk. Really important in high-risk primary prevention patients. When we look at adverse effects, importantly, no difference in adverse events leading to discontinuation, no increase in new onset diabetes, slight increases in gout and cholelithiasis. So keep that in mind. So it's currently FDA approved as an adjunct to diet and statin therapy for patients with heterozygous FH or established ASCVD. We will await obviously our new guidelines will hopefully be impaneled later sometime this year. Probably got another couple of years till they're released, but we are waiting for guidelines. We will talk about some expert consensus clinical guidance at the end of the talk. Now let's go back and revisit the newer strategies for targeting PCSK9, the PCSK9 protein. Of course, inclisiran is now FDA approved. This is a small interfering RNA that results in degradation of the messenger RNA for PCSK9 in the cytoplasm. If we think about the differences between inclisiran and the two monoclonal antibodies, with the monoclonal antibodies, the PCSK9 protein is produced, but then subsequently bound by the monoclonal antibodies to inhibit the action of the protein. Whereas inclisiran prevents the actual production of the PCSK9 protein. Again, it's an upregulator of the LDL receptor. When we look at the efficacy, the pooled, a little bit less than the monoclonal antibodies, about a 55% reduction in LDL cholesterol over time. It is FDA approved. It is to lower LDL cholesterol. We are awaiting the cardiovascular outcomes trials, but we will discuss some clinical guidance. There are multiple cardiovascular outcomes trials in progress with inclisiran. The first is Orion 4. It is expected those results at sometime late in 2026. There is also the Victorion 1P. This is a primary prevention trial that will be available in 2029. And the Victorion 2P, that again is a cardiovascular outcomes trial in patients with ASCVD, results expected in 2027. Now, the other agent that's currently FDA approved that is novel is evinacumab. And this is a fully human monoclonal antibody that is an inhibitor of ANGPTL3. So first of all, what is ANGPTL3? Well, remember that the enzymes lipoprotein lipase and endothelial lipase are the enzymes that cleave triglycerides off of VLDL and chylomicrons to form LDL and then chylomicron remnants. And ANGPTL3 inhibits that and can increase the level of triglycerides and other lipids. Loss of function variants in ANGPTL3 are associated with very low levels of LDL and cholesterol, as well as a significantly lower risk of CAD. So again, another important target for lipid lowering. Now, both variants of ANGPTL3, loss of function variants, but also agents that target, pharmacological agents that inhibit ANGPTL3 can reduce LDL cholesterol levels independently of the LDL receptor, making evinacumab, just like lomidopide we discussed, a very important agent for treating homozygous FH patients who have a defective or absent LDL receptor. When we look at the results of evinacumab in patients with homozygous FH, you can see on the left-hand side, we get about a 49%, actually, I've got that wrong, 32% reduction in LDL cholesterol levels and about 132 milligram per deciliter absolute change in LDL cholesterol levels. Here, when we look at the effectiveness in patients with homozygous FH, notice that the patients in circles are patients who have no functioning LDL receptor. The patients with triangles are those who have a defective LDL receptor, but they do have a little bit of functioning. I want you to notice that from baseline to treatment with evinacumab, both groups of patients get a near 50% reduction in LDL cholesterol. So a very important agent for these patients. Now, since the approval of bempedoic acid, evinacumab, and inclisiran, there has been an absolute explosion of additional novel agents that are in development. And I thought it would be important for us to discuss this because as you're going to some of the meetings. You'll see some of this presented upcoming. We saw some of this data at the European Society last year, just recently some of this at the American Heart Association meeting, and you're going to be seeing an explosion of new studies at ACC 24 in just a month. So let's first of all talk about CETP inhibition. So, you know, the CETP inhibitors, what CETP does is to exchange cholesterol from HDL and donates it to atherogenic lipoprotein particles, such as LDL and VLDL. And when we initially were developing these agents, it was a thought toward raising HDL cholesterol. However, you may remember, or many of you may be too young to remember, the failures of agents like torcetrapib, dalcetrapib, evacetrapib, and anacetrapib. And although they could effectively raise HDL cholesterol, they were not effective in reducing cardiovascular outcomes. We're now learning that possibly the benefits of CETP inhibition are associated with reducing LDL cholesterol. So obicetrapib is a highly selective CETP inhibitor that's undergoing clinical development to reduce LDL cholesterol. It is more potent than previous CETP inhibitors. And as you can see on the right, it can reduce LDL cholesterol by up to 50%, reduces ApoB by about 30%, non-HDL cholesterol by 44%, and of course, it can still raise HDL cholesterol. Now, obicetrapib is currently in a cardiovascular outcomes trial called the PREVAIL trial. These are patients who have LDL cholesterol that's not adequately controlled. They can be on other lipid-lowering therapy, nearly 9,000 patients, and we're expecting this trial to complete in 2026. Now, going back to the PCSK9 targeted interventions that are in development, the first one I wanted to mention, this was presented at ESC last year. So you might imagine, as you know, both inclisiran and the monoclonal antibodies are both injectable agents. The monoclonal antibodies are self-injected, but inclisiran must be administered by a healthcare provider. It would obviously be very attractive to have an oral PCSK9 inhibitor, and that's exactly what MK-0616 is. So this is under development. It is very potent against PCSK9, and the phase 1 studies showed that this agent reduced PCSK9 levels by more than 90% and lowered LDL cholesterol by about 60% after 14 days of treatment. So this is the data that was initially presented at ACC 23 last year. This was the dose ranging study. The 30 milligram dose lowered LDL cholesterol by nearly 60%. Now, this data demonstrated here, you can see reductions in ApoB of 52%, non-HDL cholesterol up to 56%, and with the majority of patients achieving their LDL cholesterol goals. In terms of safety, really a very safe agent compared to placebo. In terms of serious adverse events, there were no differences, no deaths. So really an attractive agent with good safety and tolerability. Now, the next agent I wanted to mention too is an agent called lirodalcibep. Now, this is a recombinant fusion protein. It has a PCSK9 binding domain, and then it's attached to human serum albumin. It is currently being developed for homozygous FH, ASCVD, and primary prevention. This is the data presented at ESC. You can see it's a 300 milligram sub-Q monthly dose. On the right-hand side, you can see that it achieved a 60% reduction in LDL cholesterol. And then on here at the bottom right-hand corner, you can see the majority of patients achieving their LDL cholesterol goals with liraglutide. Now, another agent is a vaccine that's being developed for PCSK9. And of course, the idea behind this is to trigger an immune reaction, antibodies to PCSK9, to neutralize the reaction again with the LDL and LDL receptor interaction. It has been shown in animal models to produce long-lasting functional antibodies, but we are still awaiting data in humans. The final PCSK9 strategy I wanted to talk with you about is the gene editing technologies. This is the one and done approach, which is to come in and permanently, through molecular surgery, make a single DNA spelling change in nearly every liver cell in an animal or a human. So this, again, instead of this approach on the left-hand side of patients going between events and then intensifying therapy when levels aren't low enough, this would be a single one and done that would be lifelong. So there are two agents in development. One is the VERVE-101 PCSK9 strategy. The other is the VERVE-201 ANGPTL3 strategy. And you can see here data in non-human primate with a nearly 90% reduction in PCSK9, a near 70% reduction in LDL cholesterol. Here with ANGPTL3, again, you can see reducing ANGPTL3 out to 2 to 3 years. I did want to just mention, I didn't have a slide here. They did just present data at AHA at about 10 human patients with VERVE-101, which showed very similar findings with safety and efficacy. They're now expanding that trial in humans, and we look forward to future data on this. Now, I don't have time to go into all of this, but I did want to take a moment just to talk about the drugs targeting lipoprotein(a). Much like the strategies for such as inclisiran, the small interfering RNA, and also the antisense oligonucleotides. There are 3 agents that are now in trials. One would be pelacarsen, which is an antisense to the production of the ApoA protein. Olpasiran is a small interfering RNA, again, to the ApoA protein, and then zerlasiran, previously known as SLN360. All 3 of those in development, and 2 in outcomes trials that are in progress. Unfortunately, right now, these are only in trials for very high-risk patients who have LPA levels greater than 250 nanomoles per liter and documented ASCVD. So for your primary prevention patients, they are not yet available in clinical trials. What I wanted to do now is just turn to a discussion of how to implement some of these evolving therapies into clinical practice. So in 2022, the American College of Cardiology recognized that we had 3 new agents, bempedoic acid, inclisiran, and evinacumab, that were FDA approved, but it had been 4 years since the guidelines had been published, and these agents were not even mentioned. So they did come together to provide expert consensus guidance on how to incorporate these agents. And I wanted to mention some important changes in the clinical guidance. First of all, this is the algorithm on the right for how you would approach a patient with ASCVD at very high risk. And remember, what is a patient at very high risk compared to a patient with ASCVD not at very high risk? Well, think back to the inclusion criteria for the FOURIER and the Odyssey outcomes trials. That would be a patient with stable ASCVD, but multiple high-risk features. Or alternatively, in Odyssey outcomes, in acute coronary syndrome patients. So that is the definition of ASCVD at very high risk. Now, you may remember in the 2018 guidelines, the recommendations were that these patients should achieve an LDL cholesterol goal of less than 70 milligrams per deciliter. That was updated in 2022 in the ACC guidance that these high-risk patients should achieve at least a 50% reduction in LDL cholesterol. And the threshold for intensifying therapy was an LDL cholesterol level of 55 milligrams per deciliter. So an important update in our LDL treatment goals. And again, this was based on IMPROVE-IT and the FOURIER and Odyssey outcomes trials that achieved LDL cholesterol levels of 30 and 54 milligrams per deciliter. Now, in terms of incorporating these agents, one other thing I wanted to mention here, the new guidance still recommends that you consider ezetimibe and then the PCSK9 monoclonal antibodies as the agents of first choice. But in this box, what I wanted you to notice very importantly is the and or in that box. And that is because it has become it's been well recognized that for high-risk patients, the earlier we achieve our LDL cholesterol goals, the lower the patient's risk. So it is now permissible to not do step therapy through ezetimibe, but rather initiate both therapies together, depending on the percent LDL cholesterol lowering that is required. Now, secondly, the bempedoic acid and inclisiran at the time of the publication of this guidance were considered second line. In light of the fact that since this, in 2023, bempedoic acid now has cardiovascular outcomes data, it is anticipated that in future guidance, bempedoic acid would be moved to the left on this diagram and be considered as a first-line agent along with bempedoic acid and the PCSK9 monoclonal antibodies. Inclisiran is still considered second line to the monoclonal antibodies, just purely on the basis of the absence of cardiovascular outcomes data. Now, in patients with FH, this has also been updated, patients with ASCVD and familial hypercholesterolemia, regardless of whether they're clinically or genetically diagnosed. Again, I wanted to point out the lower LDL cholesterol threshold now, down from 70 milligrams per deciliter to 55 milligrams per deciliter. And then in the box there at the bottom, similar to patients at high risk, again, ezetimibe and or a PCSK9 monoclonal antibody, followed by bempedoic acid or inclisiran. And then notice in box number 3 there, in these agents, you may consider treatments that do not upregulate the LDL receptor, including evinacumab, our ANGPTL3 inhibitor, or lamidipide, our MTP inhibitor. LDL apheresis may also be dialysis for LDL may be considered under the care of a lipid specialist. Now, what about in high-risk primary prevention? I wanted to just give you an update from this guidance. It's kind of a perfunctory update, But you may remember in the 2018 guidelines, there was no mention of the recommendation for ezetimibe in primary prevention. On the other hand, in this new expert consensus guidance, recognizing the difficulty of getting LDL cholesterol low enough in high-risk primary prevention, a recommendation was added for the initiation of therapy with ezetimibe. We were doing it all, and we were all doing it anyway, but now we have some clinical guidance to support it. Now, one of the other things that's new in the clinical guidance is the incorporation of calcium scoring into specific recommendations for these agents. So here are the guidance. I'm going to sort of walk you through this. On the left-hand side in this box, consistent with the 2018 guidance, you can notice that if an individual has a calcium score of 0, you can defer statin therapy and remeasure calcium score in 3 to 5 years, unless the patient has diabetes, an LDL cholesterol of 190 or greater, a family history of premature cardiovascular disease, or if the patient smokes cigarettes. But notice now in the center algorithm there, if the calcium score is between 1 and 99 and less than the 75th percentile, it is recommended that you consider at least moderate intensity therapy to achieve a 30 to 49% reduction, and you should achieve an LDL. The LDL threshold here is 100 milligrams per deciliter. If, however, you're not able to achieve an LDL cholesterol level of less than the threshold of 100, you may increase to high-intensity statin therapy. And then notice on the far right-hand side here, again, if the calcium score is 100 or greater, or 75 percentile or greater, moderate to high-intensity statin therapy. And if you're not able to achieve below the threshold of 70 milligrams per deciliter, it is now recommended to add ezetimibe. And finally, the important one that I think this probably really comes into play in your clinical practice is when you see, based on the incredibly high risk of patients with calcium scores of greater than 1,000 Agatston units, these patients have a risk of nearly equal those patients in the Fourier trial. It is recommended to consider high-intensity statin therapy. The LDL cholesterol threshold here is 70 milligrams per deciliter. And as you follow the algorithm down, ezetimibe as well as the PCSK9 monoclonal antibodies may be utilized in these patients. So let's just finish up by going back to our patient. So remember him in 1986, he was 48. He'd had an MI and bypass surgery, total cholesterol 373, LDL cholesterol 310. He was only able to tolerate cholestyramine 4 grams twice daily and niacin immediate release 500 milligrams twice daily. However, now in 2024, this patient's future is so bright, he's got to wear shades because he is now on rosuvastatin 40 milligrams, bempedoic acid in combination with ezetimibe and evolocumab. His total cholesterol is now 103 milligrams per deciliter. His HDL is 42. His triglycerides are 85. And his LDL cholesterol is 44 milligrams per deciliter. So I hope with that I have demonstrated to you, of course, the foundation of therapy remains statins, as we discussed in the beginning. But we now have 4 agents that are also evidence-based non-statins: ezetimibe, alirocumab, and evolocumab, and now as well as bempedoic acid. We have an FDA-approved therapy with an outcomes trial in progress. We have novel therapies in progress. I didn't put it on here, but obicetrapib is in clinical trial as a CETP inhibitor. We have multiple agents targeting PCSK9 and PTL3, lipoprotein a. We have an oral PCSK9 inhibitor, lirudalsibeb, vaccines, permanent gene editing, and then the 2 therapies specifically for homozygous FH. So if you were thinking about going into interventional cardiology or electrophysiology, I hope that this talk today has inspired you now that the most exciting field of cardiology right now is prevention, and I would welcome you into this space. So with that, I'll thank you, and I would be delighted to take any questions. I do see one. I'll look at this one. I see one in the chat here that says, can you comment on Repatha or Leqvio or other combinations with very high LDL not getting to target for a single agent? I think that I may have answered that in the talk. So hopefully, if I haven't, please maybe re-ask your question in a way that I better understand it. This one says, what would be the basis of ApoB LDL reduction with obicetrapib? So again, what you're doing there is hopefully inhibiting transfer of the cholesterol to the atherogenic particles. Remember, what the CTEP does is transfer cholesterol from HDL cholesterol to the ApoB containing lipoproteins. And hi, Anurag, nice to hear from you. Hopefully that is what is presumed to be the mechanism. Now, that was seen with the previous agents. They were less potent and were really more directed, and several of them had off-target side effects. You may remember torcetrapib raised blood pressure. The other question I see here is, can you use 2 PCSK9 inhibitors in combination? The answer to that question is no. There's really no pathophysiologic reason. If you have near complete inhibition of PCSK9 with one of the agents, and I think we looked at evinacumab, nearly 90% reduction in the production of the PCSK9 protein. So there's no mechanistic way to think that would be beneficial. And if you kind of think back to when we add in bempedoic acid on top of the rate-limiting enzyme with statins, HMG-CoA reductase, remember we get less reduction. So double doing something is probably diminishing returns.
Dr. Morris, we have another question in the chat.
Okay, could you speak up?
We have another question in the chat. Dr. Michael Lenhart asks about comment on the role of statin in modulating inflammatory markers.
Oh, yes, I see that. Sorry, I've scrolled past that. So, it's still unclear. I grew up in the era of, we were really, really big on the pleiotropic effects of statin. And remember, that is one of those questions that's nearly impossible to answer. The question we have for ourselves now is, do lipid-lowering agents modulate inflammatory markers through lowering LDL cholesterol? That may not be true solely, because we do know that there are some lipid-lowering agents that don't reduce inflammatory markers. So, it's still unclear. It is an issue that's impossible to tease out. Many of us do believe that the statins may have some effects beyond just their benefits in lipid lowering, but it is something that's very difficult to tease out. Let's see.
We have another question from Dr. Jonna Posen.
Okay.
For primary prevention patients, considering statin tolerability and price, how much more aggressive of a threshold for statin initiation do you expect in the updated guidelines to recommend?
So, that's in primary prevention, it's kind of hard to know. In secondary prevention, obviously, it's gotten lower to the point where we are more than capable of getting people down to the LDL cholesterol levels that are the same as those you were born with. Children are born at 25 to 40 milligrams per deciliter. So in high-risk secondary prevention patients, it's likely that we can achieve that. On the other hand, in primary prevention, it's hard to know how much lower we'll go, only in the sense that we really want to be careful. Calcium scoring has been very helpful to me to know what to do in primary prevention patients, in that we really want to target our therapies to those patients who are most likely to benefit. Remember that how we make recommendations in the guidelines are we look at net benefit, or we look at harm benefit, and we look at net benefit. So what's the potential for benefit and the potential for harm? In the broad primary prevention population, we want to be very careful to target our therapies strategically. Myalgias are real. They're not as common, they're not as real as patients seem to think they are, but they are real. And so I'm not sure how much lower than 100 milligrams per deciliter the threshold is likely to go. I do think the algorithm I showed you for calcium scoring is probably the best way to appropriately prioritize statin therapy in the appropriate patients.
Dr. Morris, I have a question.
Yes.
We do see commonly in practice that among patients with high risk or secondary prevention for ASCVD, they're usually on statin and Zetia, or maybe bempedoic acid, and the cholesterol levels are, LDL cholesterol levels are about 60, 65. And then we start PCSK9 inhibitor because we want to get them as low. But many times we get questions from primary care, some other physicians asking if we should discontinue one of the statins, or Zetia or bempedoic acid, because after starting PCSK9 inhibitors, the LDL fall quite low to as low as 20s, 10, and less than 10, and sometimes negligible amount. And the risk and the suspected risk for stroke or dementia risk. Would you please comment on that?
Yeah, so this comes up all the time, is how do you, if you think about what you just said, what you did is you started with an agent that can lower LDL cholesterol by 55% or more. So you start with a statin. You add on two agents that are somewhat less effective, but the two combined are nearly as potent as a statin. And now you've added on a PCSK9 monoclonal antibody, which is as potent as a statin. So you have three groups of, if you kind of cluster those together. And the answer is, do you need all three? And I think sometimes I try to do that strategically up front, which is that I may, if I think I'm going to need, and also with the patient. So you can decide, do you want to use an oral therapy with the ezetimibe bempedoic acid combination and see what you get? Or do you want to go straight to the PCSK9 monoclonal antibody as an injectable and maybe just add on a little ezetimibe at the end? I do de-escalate therapy if someone gets an LDL cholesterol in the single digits. So I had a patient, I'm actually seeing a patient today for whom just that patient you're discussing. I'm seeing someone today for whom I will likely delete out either the bempedoic acid or the ezetimibe, because with all four agents, I got back a calculated LDL of 0, a direct LDL of 9, and an ApoB of like 34. So there are patients for whom I think you can target. I generally target right around no lower than about 30 milligrams per deciliter. Endocrinologists like 25 milligrams per deciliter. Some of my colleagues will argue with me on that, but that's how I practice.
Thank you. We had a couple of other questions. So if LPA drugs become available and have outcome benefits, where in guideline algorithm do they fall?
Oh, that's a very good question. You know, this is going to be what I think LPA is going to take us decades to get to where we are today in primary prevention. You know, the reason for that is that we still do not know how much do we have to lower LPA for a clinically meaningful, significant cardiovascular outcomes benefit. You know, niacin lowered LPA about 30 to 35%. The PCSK9 monoclonals lower it somewhat about that same amount. And so do we know it's going to take much more than that to lower LPA and get a clinically significant benefit? So right now, only high-risk patients with very high levels of LPA are being studied in clinical trials. I suspect that by the time, I do suspect that if the outcomes trials are positive, you know, the agents now reduce LPA by nearly 90%. So that's going to be fantastic, and we really hope to see cardiovascular benefit. The issue is going to be that they're likely to be approved for high-risk patients and not be approved in primary prevention initially. So although I think we will have LPA-lowering agents in our lifetime, I think getting them to primary prevention patients is going to take longer.
Thank you. One last question before we close the session. One limitation of the newer medication is their expense. How do you take that into account when choosing add-on treatments for those who do not meet LDL goals?
Well, so, you know, one of the issues right now is, you know, bempedoic acid remains challenging to get not only approved, but also paid for. I have had some luck with GoodRx and also with the savings cards, but, you know, many of our patients are of Medicare age, and then it becomes prohibitively expensive. Time will fix that, but it is a problem. At my institution, it's easier to get the PCSK9 monoclonal antibodies approved and paid for. We have a patient assistance foundation, and many of our patients get the PCSK9 monoclonals at no cost or at a small copay. So I don't know what is the practice at your institutions, but at mine, to be quite honest with you, if I need significant LDL lowering, compared to using the combination of ezetimibe and bempedoic acid, it will be far less expensive for my patient to get a monoclonal antibody. That's just the reality of today's current payer environment. I hope that changes. As with all medications, time fixes the cost problem, but it's just not going to come soon enough.
Thank you very much, Dr. Morris.
Great. Well, thank you all so much. I know it's time, and I'm very, very grateful for the opportunity to have been here. Thank you.
Thank you.